Morning guys, it's Dr. Gillard again. We have some makeup work to do here. So we missed our lecture on congenital scoliosis last week because of Thanksgiving. So here's the makeup lecture. This stuff is actually quite important. It's on boards. I've seen it on OSCE tests. So this is some good stuff to know. Here we go, congenital scoliosis. Oh, a little quiz. Too bad it doesn't count for any points, but it's just one. What's the main diagnosis? Be specific. 12-year-old female develops chronic low back pain over the last year, which is now strong enough to preclude her from school sports. And you know that, especially if she likes it, that's a big deal. Neurological examination normal. Significant reduction in left lateral flexion with pain on end range and muscle spasm. What's the diagnosis? Well, I can hear your brains going, oh, it's just maybe not even a scoliosis. Maybe it's just a curvature, maybe a Lenke 5A at the worst. But remember, the Lenke system, although you can use it to describe congenital scoliosis curve structure, you're really not supposed to. That's designed for AIS, right? Adolescent idiopathic scoliosis. So there's something, this is not an AIS scoliosis here. What is it? Well, some of you might have noticed we got a missing rib. Certainly not, well, you could say agenesis of the 12th rib, but when you see, what's the rule? When you see something missing, you always look for something else missing or something weird. And we got quite a bit of weirdness going on down here, but that's not what I'm after. Some of you saw it. So if you're counting pedicles, 1, 2, well, you can see these pedicles are all nice, but what's this thing? You guys see it? So that's a hemivertebra. That's a vertebra, just a little wedge of cheese that's stuck in here. In fact, because it has a disc space here, but no disc space here, it's a semi-segmented hemivertebra, which is a complete failure of formation. And that's the whole topic. If you understood exactly what I said, you're going to have a very easy time. And I think you have been taught this stuff by one of the DACBRs. But if not, we're going to go over it again. And if you can't see it, let me try my new drawing tools here. We're going to experiment a little in this video. So the little chunk of cheese would be, here's the bottom of it. It's even got a little TP. And right here, you can't see it, but it's fused. Oh, it doesn't let me do the dots. And there's the pedicle there. But it's fused to, that would be 1, 2, it's fused to L2. So how would you name that? That's L3. These are almost always supernumerary bones. So you would say a supernumerary hemivertebra between L2 and L3. Let's see if I can erase that. Okay, awesome. Let's move on. Oh, I guess I could have drawn it there. You guys can see it again, right? Right there. This is actually something as well. Didn't notice that. What's that one? That's actually a wedged vertebra. That kind of started the scoliosis off. So that's a partial failure of formation. So we'll talk about that. Let's get talking about this stuff. Here's the answer. Everything I said. Let's go. Congenital scoliosis. A scoliosis that occurs secondary to a congenital defect. What's that mean? That's something you're born with. Something went wrong during embryogenesis. It can be of one vertebra, can be of two vertebrae, can be of a whole bunch of vertebrae. And this is the most frequent, or it's the most frequent cause of a congenital deformity of the spine. It's not hemivertebra, but it's a problem with the vertebra. So runners up, second and third place, most frequent would be a congenital kyphosis, which is also caused by a failure of formation only of the anterior columns. Let's see, would that be right? Yeah. And then a congenital lordosis, which is pretty rare. That's a congenital failure of the posterior column, failure of formation. Anyway, congenital scoliosis represents 10% of the scoliotic pie. So all scoliosis diagnoses, remember AIS was by far the biggest. And it's often associated with the presence of other congenital defects. This is the key right here. This is one take-home message today. If you ever see one of these things in a child especially, and this is all new news to them, you have to watch out, because almost a third of patients have problems with other regions of the body, including things like a syringomyelia, we'll talk about them, like a syrinx within the spinal cord, or a tethered spinal cord, or heart problems, bladder problems, kidney problems. So that's the big take-home message here. So you need to do a little referral work and some other testing on these patients. Okay, congenital scoliosis. I think is that the one we just saw? Nope, that's a little different. What do you see here? That's another one. It looks like almost the same thing, but there's another semi-segmented, complete failure of formation, a little block of cheese right here. Most cases of congenital scoliosis have not been associated with hereditary factors. So if you have one, your children may not develop this. We can't find genes for this thing. The exception to the rule is if you have multi failures of segmentation, or other multiple hemivertebra, or failures of formation. I guess the specific study just looked at multiple vertebral levels of segmentation failure. So we'll talk about failure of segmentation. That's your block vertebra. Some authors believe congenital scoliosis arise from an injury or insult to the fetus that occurs between the 5th and 8th week of gestation. So something happened probably before the mother even knew that she was pregnant. Maybe she got x-rayed, or she had a hard night of partying, or who knows what happened. But something happened, we still don't understand it. The same gestational injury theory is also responsible for the other comorbidities that often exist, including heart, kidney, spinal cord malformations, as I just said. And congenital, who cares about this? Because congenital scoliosis, even more so than AIS, those curves like to progress, sometimes dangerously. You can get big curves where you have trouble with lung volume, and people can actually die from this if it's severe enough. So we definitely need to know about it. In fact, 75% of these curves are progressive. So that's much higher than AIS. Even more troubling is the fact that half of that 75%, so if you have a curve that's progressing and you have a congenital scoliosis, they're highly progressive and will require at least bracing and hopefully not surgery. What's the surgery marker number? And we'll cover this somewhere in the slides, but what's the magic Cobb angle? About 50 degrees. 40 degrees and increasing, it's time to make referral to a orthopedic spine surgeon. One who specializes in scoliosis, though, right? Because this is not, let me turn this a little bit. This is not something your average orthopedist who does carpal tunnel, maybe he does shoulder, maybe he does a back. You want someone who specializes in scoliosis surgery for this, because remember we talked about AIS, we talked about the different types of surgical options for this, and we saw the huge complication rates over 10%, which is, that's reported, that's notwithstanding publication bias, it's probably more like 20%. So need a specialist. Now I don't want to keep rambling too much because we need to get through this. Although CS may be picked up on a routine prenatal ultrasound, they're typically caught on a health examination, a primary healthcare provider routine exam like you're going to do. And some of the evaluation findings include the Franz beard, a hairy patch on the spine. I'll show you some crazy big hairy patches here in a second, but they don't have to be that big. They can be little ones. And that's the Franz beard is I can never say this word very good. Diastematomyelia. I don't think we'll talk about this here, but I don't know if I'll get to that this quarter now. I'm sure someone's went over that. And then there's the nevus flammeus, or the famous port wine stain. Always raises an eyebrow. Never adjust a little kid if you're going to use a grade 5 manipulation if he's got a port wine stain, right? Because you could have a spina bifida. You don't know what's down there. You need to do an x-ray on that. And then there's sacral dimples. The big one, though, that school nurses do, or they used to do, I don't know if they still do anymore, but is the Adams test, or the bend forward test. There's a bunch of AKs, but it's known as Adams test. Just have the patient bend forward and look for hunching. See the hunching right up here? Scoliosis. So not a good thing. Need an x-ray to see what's going on, to get a marker of that, and track it to make sure it doesn't get too progressive. There is a crazy fawn's beard. And this patient had congenital scoliosis. There's another one, severe congenital scoliosis. I think it's called fawn's tail as well. There's a couple AKs for it. There's nevus flammeus, or ural port wine stain. There's a sacral dimple right there. One of our grandkids actually has one of this, so he doesn't have any problems yet, so we're not going to x-ray him yet, but in the back of my mind I'm thinking, okay, what's going on down with that lumbar spine? So it almost looks like a second anus, doesn't it? But that's called the sacral dimple. Just like idiopathic scoliosis, the scoliatic deformity may significantly worsen during the child's growth spurt. So remember, that's one of your jobs if you're going to treat a patient like this who has pain, is you need to monitor that scoliosis, that scoliotic curve, to make sure it doesn't get worse, right? Here's some rules. So when are the growth spurts? Researchers are a little off on this. I like a paper by Arlett, did a very good job. It's in the mid-2000s, but very good paper on this. 0 to 3 is the growth spurt. I've seen 0 to 5, but 0 to 3 we'll use. First couple years we'll probably use if I ever tested you on that. And then the start of adolescence, which is about 10. Remember, some people start early. Those are the dangerous periods where you got to watch these things like a hawk. And the rule is, if the curve increases by more than 10 degrees in a single year, it is concerning, and you need to probably initiate an orthopedic surgical consult, assuming they have a curve. If they have a little 20 or 15 degree curve, you can keep watching it. But if now the curve is up to 40 degrees, off they go to your orthopedic spine surgeon that you commonly work with. Imaging, all patients with examination finding for scoliosis should be x-rayed. We said that. We want to get a baseline so we can watch this thing over a year. That's actually very important, to get a baseline of this. Even if you get them better with a couple treatments, then at least you have a baseline, and maybe you'll see them in a couple years, and scoliosis is increased by 20 degrees, and then you got a problem. And those should be done, well, you can read that. Full spine, PA, lateral images should be done as well. Lateral bending images as well, right? If you want to classify this thing, because you can use the Linky system if you want to communicate with somebody. So we talked about that before. MRI is the gold standard, and not only can it differentiate from semi-segmented to fully segmented, it can really hone in on the diagnosis much better than radiographs. But it might show some cord abnormalities. Maybe there's a syrinx that pops up. So definitely don't. I go on a little rant at the end of this about how I guess our Palmer, the big school's official policy is you can use a grade 5 manipulation on these without ordering an MRI, and I don't agree with that. So I would rather see what's going on down there, because a third of these patients could have a defect in their spinal cord, and you don't want to do a grade 5 over a syrinx or something like that. Anyway, we'll get to that. Okay, what's this? We didn't look at too many of these, but this is a to P, a coronal image. You can see the psoas shadows here quite nicely. There's the vertebral bodies. You can see the discs here in this little guy. And there is the culprit. So that's a complete failure formation. That's a hemivertebra, and it's got 2 discs, little bitty discs. So this is a normally segmentation was normal in this case, and these are dangerous because if they have disc bases, that means they have epiphyseal plates, and the ring apophyses are working, so it can grow like crazy and really cause a scoliosis. We'll see a hierarchy of these things in a little while. So hemivertebra with normal segmentation or fully segmented hemivertebra. Imaging, more imaging. The CT scan is nice as well for the complicated deformities. You can get a 3D reconstruction. You should order it with thin slice, and it should be 3D reconstruction, so you can really hone in. Surgeon needs that to figure out his strategy, how to fix the thing. Should you not be able to take care of the patient. If a bony bar is suspected, and we'll talk about those, CT also increases the chances of visualizing the defect more thoroughly, which could lead to a better classification. Wow, what's going on here? Here's a you guys know what this is. CT 3D reconstruction. Thoracic spine, obviously we got ribs on this side. So we got a bunch of a bunch of wedges. We haven't even talked about them yet, but a wedge, hemivertebra usually does not pass the midline. So a wedge will pass the midline. That's called a partial failure of formation. They have 2 pedicles, and they can cause scoliotic defects as well. There's a whole bunch of these in a row. So what's going on here? It's like it's welded together, isn't it? That's called a unilateral bony bar, and we'll talk about that. There's a beautiful image. Got it? Yep, right there. There's a complete failure of formation, and it is completely segmented. So this is a dangerous little guy right here. Maybe a little bit of a wedge. Look how the axial line, the weight of gravity will be coming right down here, and this is all messed up biomechanically, and look at how the body is responding by growing a bone spur right here. Body is very smart. Try not to ramble, Dr. Gillard. I can hear you saying right now. Strategy. So early detection and close monitoring are the keys to successful management. Remember, the pain on these things is kind of a secondary thing. We're more worried about having a dangerous curve, that gets to over 100 degrees and you're not paying attention, and you can injure the patient's lung, or they could even die. So got to keep an eye on that. Failure to accomplish the above strategy may result in significant spinal deformity, pulmonary restriction, neurological problems, and even death. Curves greater than 50 degrees which still have the potential to grow. So if you got a kid who's 12 years old and has a 50-degree curve, you're in trouble here. They should be in a brace already, and you need to set up a spine surgeon consult ASAP. They're probably going to need some type of surgery, because it could double, could go to 100 degrees or even more when their big growth spurt hits. All right, got a nice curve right here, and there's fusion wasn't terribly successful, was it? It's the old hook. Oh, let's look at that. What happened here? This is an AIS. This is not a congenital. That's that old hook and rod system. See the hook pulled right out. Failed surgery. So you can still see the curve. So remember, we don't use that. We use segmental pedicle screw fixation now. Anterior, whether it be anterior or posterior, it's still debatable. Posterior. Anyway, I'm rambling. Let's go on. Okay, classification, a big star here. McEwen gave us a classic classification system, and there's 3 main classes of congenital scoliosis, which of course can intermix. So I've been talking about some of these. Let's nail these down a little more. There's failure of formation. failure of formation or formation defects of the vertebra. There's a partial failure of formation. There's a full or complete failure of formation. So the hemivertebra would be a full failure of formation. The wedge vertebrae and the butterfly vertebra are partial. Butterfly we're not going to talk about, kind of rare. Don't have time today, but I'll probably inject this into the class over the next few quarters. But a wedge vertebrae is a partial failure of formation. Then we have segmentation defects, failure of segmentation. So we have a blocked vertebra, an unsegmented bar, can be unilateral. Blocked vertebra, you don't really say it's a bilateral unsegmented bar because it's much more than that, but that's really what it is. So if it's an unsegmented bar, there's just a bar like we saw already on one side. A block means it's just a block. The motion segment is fused together into one. And then there's a little confusing part because we also, hemivertebrae, we also talk about a kind of a second classification system of these hemivertebrae where we actually talk about segmentation defects within them as well. So it's a little confusing. You'll see when I get to hemi. But segmentation defects in and of themselves, or failure of segmentation, refers to a blocked vertebra or a unilateral unsegmented bar. Should have put unilateral there. And then we have mixed defects all the time where you can have a mixture of bone. Doesn't happen too often, but of course in some of these images we are going to see some mixed defects. Approximately 80% of the vertebral anomalies which occur with congenital scoliosis fall nice and neatly. 20% are mixed. So I don't want to say it's rare, but 20% is significant. A couple sources, that's only one source where this came from. There's a newer classification system introduced in 2009, and it's wonderful because it uses three-dimensional CT to really dial in on these things, but it's very complex and it's definitely beyond the scope of chiropractic boards. Okay, failure of formation. When I think of that, what do you think of failure of formation? You think wedge or hemivertebra? So let's go over it officially. It's a failure of the region of the vertebra. Sometimes the whole vertebra just doesn't show up, but it's a failure of the vertebra to form. It doesn't form normally. It can be partial, it can be a complete defect. We said that a hemivertebra is a complete failure of formation, and a wedge defect is a partial failure of formation. And it's the most common cause of congenital scoliosis, period. Defects in vertebral formation can classically occur in 3 locations. So almost always these are lateral defects. So these result in our coronal scoliosis. That's what we're going to focus on. We're not going to worry too much about these others, but there's an anterior defect. If the entire vertebral body fails to form, you can imagine, and the posterior elements form, the facets and everything are there, you get a severe flexion deformity, which results in a severe kyphosis. Same on the posteriorly. You get a severe hypolordosis if the facet joints don't form. So those are also in play, but kind of beyond the scope of this, I think. There's a nice paper on it there if you want to read more about that. Complete failure of formation may occur in isolation, or it may occur in combination with another congenital defect called a failure of segmentation. So this is kind of tricky to understand. So specifically, only complete failures of formation, which is a hemivertebra, are classified further using segmentation. Remember, we had the failure of segmentation was the second major class in and of itself. But we also use that same classification system to further describe hemivertebra. And I like to think of it as a vertical, because we're talking about verticalness here, vertical failure of segmentation, failure of segmentation. And the block vertebrae and unilateral bony bar, we're talking about more vertical. Did I say horizontal? So I might have messed that up. So let me start that again. So when we're using segmentation to classify hemivertebra, we're talking about the end plates, and so that's horizontal. So you could actually say it's horizontal failure of segmentation, full horizontal partial failure of segmentation, or a horizontal fully segmented segment. So it's confusing. Read through this a couple times and you'll get the hang of it. Partial failure formation. So in a partial, so this is a wedge vertebra. The transverse diameter, which would be across here, right? Vertical, transverse, same as horizontal, same as axial, hat, horizontal, axial, transverse, all AKAs. So the transverse diameter of the vertebral body is normal, but you have a wedge here. The vertebral body is either wedge shape or trapezoid shape. And the key is it does have two pedicles. So both pedicles are present, as you can see. However, one may be so hypoplastic you might not be able to see it. So here's three hemivertebra, boom, 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 causing a scoliotic curve here. And this is classically called a wedge or wedged vertebra. Okay, wedged vertebra. And you don't use that extra failure of segmentation. These wedges are almost always segmented, so you don't use that extra failure of segmentation. Like, is this a partially segmented wedge? You don't say that. It's just a wedge, which is a partial failure of formation. I guess this is kind of confusing, isn't it? But you'll get it. Complete failure of formation. So hemivertebra, complete failure equals hemivertebra. Transverse transverse diameter of the vertebral body is typically less than 1/2. It's just a little chunk of cheese in there, caused by complete failure of formation on one side of the vertebra. Usually, the vertebral body is affected. A vertebral body is trapezoid or wedged, or could be a little wedge, but it doesn't extend more than 50% across the disc space. True hemivertebrae only have one pedicle and one lamina. They do still have a posterior arch. They have a facet joint, and they have all that stuff. And this is called a hemivertebra. There's a really nice picture of a run-of-the-mill hemivertebra. So again, it's a complete failure of formation, results in a wedge shape, one-eyed pedicle. Should have drew a little eye on him there. And typically occupies less than 50% of the adjacent end plate. And now let's go further. I said we can classify hemivertebrae. We can also use that segmentation, specifically horizontal segmentation rule, to classify this. So in this cartoon, you can clearly see there's a disc space here, and there's a disc space here. So this is a fully segment. This is normally segmented. You say this is a fully segmented or normally segmented complete failure formation, or a hemivertebra that is fully segmented. And that will tell us these are dangerous. These are one of the most dangerous types, especially if there's a bone bar, unilateral bone bar on this side. Very, very dangerous scoliosis, as we'll see. The affected vertebra is typically hypoplastic. What's that mean? Smaller than normal. We know that. It's just a little chunk of cheese. Maybe completely absent. You may have nothing there except the posterior arch and elements. It's kind of rare, though. I won't show any pictures of that. But the pedicle is typically normal and may even be enlarged. Hemivertebra may take the place of a normal vertebra. So you might be able to count like L1, 2, 3, 4, and L3 is clearly a hemivertebra, a wedge. But more often than not, it's an extra bone that shouldn't be there. It's just the body has formed an extra bone. So that's called a supernumerary hemivertebra, and that's almost always the case. In fact, the lateral hemivertebrae are typically supernumerary. One source, there's a lot of, that's pretty much undisputed there. And so what? Who cares about this hemivertebra? Well, just like you're going to fall a tree, you're going to drive wedges into the tree. as these wedges, let's pretend these wedges could literally grow as the child grows. It literally will fall the tree. Although your spine's not a tree, but it'll make it curve. So it increases the unilateral longitudinal growth on one side of the spine and not the other. So a fully segmented hemivertebra, so it's got a disc on top and bottom, has a greater severe curve causing potential than a partial segmented vertebra or a non-segmented vertebra. So fully segmentation is a bad thing. So to be normal in this case is not good because it could increase the scoliosis. So hemivertebra induced scoliosis, there's a wedge. Just think of that chunk of cheese driving in here. You can easily see how it's tilted the tower here, even though the body has naturally corrected itself for now. There's another nice image. You can see the chunk of cheese, fully segmented, right? You can clearly see two joint spaces. Fully segmented supernumerary hemivertebra. Some fun facts. Nice to make test questions from these types of slides. Hemivertebrae in the thoracic spine are often accompanied by an extra rib, even though this extra rib may be smaller than your typical rib. We'll see a nice picture of that in a minute. And look for these hemivertebrae at the apex of the scoliosis, because that's where you're driving in the wedge of cheese, right? So that usually creates the scoliosis above and below. Look at this for a second. Give you a second here. What do you see? Or I guess I don't have to give you, you can pause it. Well, here's some nice normal ribs over here. You can see some nice vertebra. Very young child here. Still growth potential going on. Almost looks like a butterfly vertebra right here. In fact, it probably is. But still normal ribs. Now, once you get up here, you got all these little hemivertebrae, 3 of them in a row. And look what has happened to the ribs. So there's a whole bunch of extra ribs in there. There's 1, 2, 3, 4, 5, 6. To the other side, there should be 3 or maybe 4 at the most. But they're little tiny things. So when you see that, you know, even though it's hard to see the hemivertebra in here, that's why I'd get an MRI and they'd show up beautifully. But this is a bad sign. You know there are hemivertebra in here, multiple hemivertebra. Well, let me look at one thing here. I'm trying to see what caused the curve in the first place. Agenesis of a rib there. Yeah, it looks like we need to see one further down to see what started the tower leaning. Hemivertebrae developed at the lumbosacral junction is very bad, right? If you drive a wedge in at the bottom of a tree, it's going to fall. The whole tree's going to fall, so you can get double, triple scoliosis is that way. So bad prognosis. Best to take how do they treat this? Beyond the scope of this, we won't get into the treatment, but they can just literally go in there and take the darn thing out. They can cut the little guy right out. And sometimes they'll have to use some traditional techniques as well to fix the scoliosis. But down the lumbar spine, you could get a pelvic obliquity with the sacroiliac joints become skewed. So they're very complicated down in that region. What's the diagnosis here? Well, you can see a big hemivertebra. It's actually crossed the midline, but it's only got 1 pedicle, so it's not a wedged vertebra. If wedged vertebra would have 2 pedicles. So a big pedicle here. That's probably right at the level of the iliac crest. That's probably 4, but it could be supernumerary. But I don't think so. I think this one is a real hemivertebra of 4. So failure of formation, complete failure of formation with, we'll just say, a L4. Answer, there's your answer. Further classifications. Now, fully segmented, or just a no, it should be fully segmented, not just segment. I should change that, or completely segmented. The vertebrae has normal segmentation, so it's developed during apophyses on the superior and inferior input, and that's not it's a bad thing, right? Because it has huge growth potential. And yeah, by far the most common presentation, according to a couple sources, one of our texts, Rothman-Simeone, and has the highest likelihood of causing a severe progressive scoliosis. with a caveat. I'd said if there's a bone bar on the other side, if it's a mixed, we'll see the hierarchy in a minute. So Rothman, Simeone. I'm not starting to like that book. I might even drop that down because I find myself going to the research to make the whole story when they should have really done this work for me, especially because it's so expensive. I am digressing again. I will stop that. Semi-segmented or partially segmented is it AKA. So, and that means, and remember, we're talking about these horizontal, that's my word, but that's the way I keep it straight in my mind. So these are horizontal semi-segmented. So the vertebra is not properly segmented. One of the end plates is fused with the adjacent vertebral body. So the growth potential is not as severe with this. The curve progression potential is not as severe. I think we talked enough about that. Non-segmented. Didn't we just talk about that? Fully segmented? No. Non-segment is easy. Neither the superior or inferior end plate has segmentation. In other words, the superior and inferior end plate of this little hemivertebra are grown right to the adjacent vertebral bodies. So you may have a little scoliosis just from the wedge that you drove in there, but it will never progress because there's no growth potential. It has no end plates. It can't progress. We have an incarcerated. I don't think I even have any examples of those except cartoons. They're quite rare, but you could get a hemivertebra, which is fully segmented and dangerous, guns loaded. However, the adjacent vertebrae happen to be partial failures of formation. What's partial failure formation? That's a wedge. So you have two opposite facing wedges that basically take the punch out of that hemivertebra. They offset it. So the adjacent wedge vertebrae typically compensate for any uneven growth generated by fully segmented vertebrae between them. Therefore, not much scoliosis can result. If the hemivertebra is non-segmented, then no scoliosis. So you could have an incarcerated non-segmented scoliosis, or incarcerated non-segmented hemivertebra as well, and that will not grow. Here's a picture. Sometimes it's best to understand this. So this is the typical scenario, although again, remember it's rare. So here's your hemivertebra here, pedicle's not drawn, and is it segmented or fully segmented? Or I'm sorry, is it partially segmented, partial segmentation? No, it's fully segmented. It's completely segmented. So we have segmentation has occurred on the top, segmentation has occurred during embryogenesis on the bottom, and wonderful. So why don't we have a scoliosis? Because if you look above, we have a partial failure of formation, aka a wedged vertebra right here. And then below it, we have a wedge running the other way, so it negates the effect of this. You might still get a little bit of scoliotic curve in this one, but not very much at all, because the original wedge has basically been taken away. And here we have a completely non-segmented hemivertebra, non-horizontally segmented, because they just drew these lines in there so you could see the thing. And then this original wedge has no growth potential. And then you have a wedge above and a wedge below that have offset this. So this has zero growth potential. So these are both incarcerated, but they're both incarcerated. This is a fully segmented incarceration. This is a non-segmental incarceration. Has zero growth potential. Zero scoliosis potential, and this one has very minimal. There's different types here. Again, kind of a review here. So here's this hemivertebra that is fully segmented. Rothman-Simeone just call it segmented. I think it's better to just say it's completely segmented or fully segmented. You can see it's two end plates. And what's wrong with their drawing? It rarely extends all the way. So again, I'm not happy with this book. Although it's still got some good material on the other side. They could have done a lot better with this. Now this one, okay, here's a hemivertebra. They didn't even draw a little helper line here. And this is how you'll really see it on x-ray. It'll look just like this. So that's a semi-segmented hemivertebra, what's a hemivertebra again? It's complete failure of formation. Here's an incarcerated, fully segmented hemivertebra here. Again, I don't like how they've drawn this so far. And here's an incarcerated, non-segmented hemivertebra here with 0. Slight scoliosis potential, much greater scoliosis progression potential, not as much scoliosis progression potential, even less scoliosis progression potential, no scoliosis progression potential. The numbering, we talked about this, it can be confusing. Hemivertebra is typically a supernumerary bone, we already said that, which shouldn't be there. Therefore, you would name it in between two segments. Already talked about this. Occasionally, like that one we saw at L4, it actually replaces the vertebrae. I think we talked enough about that. Partial failure formation with normal segmentation. And we don't, again, I shouldn't have even said that because most of the literature doesn't say normal segmentation. But still, I would understand, especially if I said partial failure formation with normal horizontal segmentation, I would know there's discs, which there usually are. Okay, what's going on here now? Time to test your brains a little bit. Kind of a wake-up quiz. Well, good, scoliosis, but why? Oh, I don't have to wait, right? You guys are pausing this. Okay, look, I don't see any hemivertebra per se, but a whole bunch of partial failure formations or a whole bunch of wedges. So wedge here, more severe wedge here, wedge going the opposite way, wedge going the opposite way to correct this. And a bunch of extra ribs, right? Or one extra rib for sure. I think if we took that one rib away, we would be okay. So I don't think there's a hemivertebra hiding in that one. How about this one? We actually saw this already, right? There's extra ribs. Lots of hemivertebrae. It's hard to see. We would need a CT or an MRI. Okay, now failure of segmentation for real as a standalone category. Or if you want, I don't see why you can't say failure of vertical segmentation. And then that would differentiate from the horizontal segmentation, which is only used to describe hemivertebrae. I should write a paper on that, shouldn't I? Failure of segmentation. So occurs when, we know this already, kind of. Occurs when two adjacent vertebrae fail to separate, period. The end plates fail to separate during embryogenesis. Specifically occurs when the adjacent somites and associated mesenchyme fail to fully separate, which results in no growth plate formation, so there's no growth potential. That's a Rico 2009. I like to call these vertical failures. I already said that. Vertical failures of segmentation to differentiate from horizontal failure of segmentation, which only describe hemivertebra. I should have said only describe hemivertebra. Can occur unilaterally, then we have a unilateral bar, or bilaterally, then we have a blocked vertebra. We won't worry about anything else. So partial failure of segmentation, aka unilateral failure of segmentation. See, that's where that vertical segmentation would be nice. Adjacent vertebral bodies partially fail to separate. So these are also, I could put aka unilateral bar here. I probably should have put that. And this is a brand new PowerPoint, by the way, even different than last quarter. So this will get worked out over the next few quarters. Very common cause of congenital scoliosis. In and of itself, it is not as common as a hemivertebra, though. Results in the formation of a unilateral bony bar, which spans between adjacent vertebral bodies. And it could go 1, 2, 3. It can be quite large. Nice cartoon, Rothman Senior. Oh, I'm not sure where I got this one from. Partial failure. So unilateral bony bar fuses with the disc space, pedicles, and facets on that side. And there's a cartoon of it. precludes longitudinal growth on that side, right? It can't grow. There's no ring hypothesis here. It's fused, but it can still grow over here. And it can bend this, like bending a little stick, a willow stick. It won't break it, but it'll bend it as this grows. It ultimately will become the concavity of the scoliosis. The concavity would occur here. If a hemivertebrae was here, I think that's a question on the final. If a hemivertebra was here, it would be on the same side as the concavity of the scoliosis. Make sure you know that. Another cartoon, multiple partial failure of segmentation, congenital bar. Now these congenital bars aren't always nice and pretty like this. They could be anteriorly, laterally, or they could be a mix, so they can be anywhere, although they often do occur laterally like this to create a scoliosis. Now, what's going on here? 2-year-old child. Pause it. Oh, that's right. See, I don't get a water break when I don't pause. Anybody see it? There it is right there. It's like, well, that's just the pedicle. No. Count your pedicles. 1, 2. 1, 2. 1, 2. 1, 2. These are together. So this is a beautiful example of a unilateral bony bar, which is a partial failure of segmentation. Partial failure of vertical segmentation. I like that better. Answer, there it is. So the real answer is the diagnosis is a congenital scoliosis as opposed to childhood scoliosis or infantile scoliosis or AIS. Congenital scoliosis now because you have a congenital blocked or a unilateral bony bar here. Complete failure of segmentation. So a bunch of AKAs, bilateral failure of segmentation, unsegmented bar, unsegmented bony bar, congenital blocked vertebra. So these unsegmented bars can be the same thing. Circumferential symmetrical failure of segmentation. So there's no vertical. Well, does that work? Not for this. There's just no segmentation. There's no disc. There's no ring hypothesis. So it leads to a blocked vertebra. You could think of it as a bilateral bony bar, but it's more than that. The whole it's much more than just a bar like we just saw, typically. In other words, adjacent vertebral bodies completely fail to segment or separate in vivo and during embryogenesis. And what's that going to do to the height of that individual? Well, if he has no disc, he's going to be shorter a little bit. And if he has a whole bunch of these, he can be definitely shorter. Oh, I forgot to put my clipophile picture in. That just must be coming up. It just popped into my brain. You can look that up when we get there. I'm digressing, back on track. Unsegmented bar halts longitudinal growth period. So you're shorter, results in no spinal curvature in and of itself, and decreases vertical height of that motion segment. I think we got that message. Yes, should have a nice picture of clipophile syndrome. If there's multiple cervical complete failures of segmentation or multiple blocked vertebra, you get a short neck. And that's part of the syndrome of clipophile syndrome. I think there's an upper cervical class too. I'm sure they talked about that in there. Okay, what do you see here? Well, good. Scoliosis. Is it idiopathic, or do we know why? Now we got some wedges in here, right? There's a wedge. There's a wedge. There's a wedge. Looks like there's an extra rib in here somewhere. So, is there a hemi in there as well? So we got a block at T9. T9 is also a wedge vertebra, partial failure formation. So this is a mixed type. This is a mixed type. We got a block. Yeah, I guess you would say. There's a rudimentary disc space here. But I guess that's enough together. This author called it a block. So I guess I'll buy that. But I can see the pedicles, which makes it a little strange to me. And I can still see a rudimentary disc space. So this is why that other classification system shines, because it takes care of all these types, but it's way too complex to talk about. Some bad prognosis is some patients with a unilateral failure of segmentation. There may also be one or even more hemivertebra on the opposite side. So that's a bad thing. A bone bar on the left with a hemivertebra on the right, you have double growth potential, double curve progression potential, which is a bad thing. So they can reach 50 degrees, that magic number, within 2 years of these things. So these are very, very dangerous. Hemivertebra, the prognosis for curve progression is based on 3 factors. The patient's age, right? Was he before or after the growth spurt? Where the defect is located, and the exact type of anomaly. Is it just a hemivertebra, or is it a unilateral bone bar with a hemivertebra on the opposite side? That's really bad. Typically a fully segmented hemivertebra. So fully segmented, so that's got two ring apophyses and can grow. It produces a scoliotic curve increase rate at a rate of 1 to 2 per year. And that's, you have to be careful and watch that. And you probably can brace them if they're getting close to 40 degrees or even 35 degrees or so. They should be braced, because you don't want them getting near 50 for sure. Lower thoracic and thoracolumbar placed hemivertebra are more aggressive, cause more aggressive curves. And 2 adjacent same side hemivertebra double increase the danger of severe, especially if they're fully segmented, right? That just makes sense. Multiple hemivertebra, on the other hand, sometimes the hemivertebra can be strategically placed on opposite sides of the spine so that they can actually kind of negate or mitigate the scoliotic curve. So look at this cartoon. Hemivertebrae here on the left, and then starting to curve, and then whoa, we have one here on the right. This one's fully segmented. This one is non-segmented, so it doesn't have as much potential as this one. But then we got another fully segmented hemivertebra right here to offset that further. So this is a good thing. Proximal thoracic scoliosis. Remember the ones up high in the thoracic spine? They never get bigger than 30 degrees, which is good. But these are the ones that can cause the severe shoulder unleveling, and they can be very disfiguring. So semi-segmented hemivertebra cause a less rapid curve progression, but they can be more cosmetically of a problem. And these curves are generally less than 40 degrees at skeletal maturity. And this source here said they don't go 30, so 30 to 40 is the number here. So here's a chart. I forget where I got this from, but a recent research paper. And this, all the authors agree with this. It's fully segmented hemivertebra is the worst one. Fully segmented hemivertebra on the left with a right-sided unilateral bone bar right across from it at the same level. So let me think about that a minute. So yes, so it's like so this unilateral bone bar acts as a fulcrum point. So very dangerous situation here. Then a unilateral, all by itself, unsegmented bar is the second most dangerous. I can see a test question coming up from this. Didn't have this last quarter, so mix up that test a little. Two consecutive fully segmented ipsilateral hemivertebra. So hemivertebra on the right at, let's say, T7, T8, and another one at T8, T9 on the same side. That's third place. Semi-segmented hemivertebra. Okay, so one that just has only one end plate for growth potential. And then we have a wedge vertebra, so partial failure formation. And then that's just like driving in like the block trying to fall the tree. And then incarcerated hemivertebra. There's two types of those. And then note again, the blocked vertebra has no curve potential whatsoever because it has no ring apophyses. And see unlevel shoulders here in this young girl. Not a good thing. Multiple hemivertebra in the proximal spine. All right, I think that's all the information part. Now let's just try to practice getting some of these. Okay, what do you see here? Okay, you paused it, you're back. Good. We have a unilateral bone bar right here. So this is a partial failure of segmentation at 11, 10, at 9, 8, and 7. So there's a unilateral bone bar at reading right at those levels. So that's a partial failure of segmentation. There you go. Oh, and whoops. I forgot. What did I forget? Going too fast here. So there are some wedge. This is a wedge, right? So this is a partial failure formation on top of that. This one, all three of these are really, you can hallucinate in there. So this is definitely a mixed type. Now what's going on? Well, this is just to show you. So it's a unilateral bar, but it's not, on this one, it's not lateral, it's posterior bar. Nice 3D reconstruction there. Wonderful. There you go. Let's do another one. Okay. I'm just naturally pausing, but I don't have to pause, do I? So we got, I don't see any bars. We did this one, I think, already. We have an extra rib. These are just a bunch of wedge vertebra. So partial failure of formation. Wedge vertebra causing a scoliosis. What about this? Oh, this one's a little trickier. This is not a child for sure. Okay, you're back. So look at that bone spur that's grown here. To me, it looks like we have a hemivertebra right here. We definitely have wedges, so this is a mixed defect for sure, because these are wedge vertebra, and it looks like if I had all the disc, we could go through this and see for sure. Looks like it's a partially segmented hemivertebra here as well. That's a tough one. Geek alert. Okay. What kind of deformity is this one? Okay, you're back. So looks like we definitely got a wedge here. So we got partial failure of formation going on. This is definitely a hemivertebra, even though it's a longer one. See there? Where's the other pedicle? There's no other pedicle. This is full failure of formation here. And let's count. So that's 12. 1, 2, 3, 4, 5. So that's a supernumerary for sure there. All right, got that supernumerary between L2 and L3. Notice how I write that out. L2 is wedged as well. Partial failure formation. Some funkiness down here at 5-2. We can't, without a CT, we can't see any better than that. What do we have here? Oh, now we got a radiograph. See how nice the MRI is? It really solves the story for us. So yeah, hemi. Got a hemi right there. Here it's hard to tell. Is it the segmentation? Is it fully segmented? Is it partial? It's really hard to tell. Not on the MRI. You can clearly see it is fully segmented. So it has bad growth potential. Plus, it started a pretty nasty scoliosis down here. I mean, there's probably, this looks like a wedge here as well, maybe a wedge, a bunch of little wedges, but that's the big smoking gun there. It looks like there's agenesis of the 12th rib. I don't see a rib here either. Okay, complete failure of formation, fully segmented supernumerary hemivertebra, and arguably some wedges in there. Although we can look on here. Yeah, this is wedged, right? It's higher here than here, so that could be wedge. But that's the major diagnosis. How about here? Okay, your back. I think we've seen this one. Agenesis of the 12th rib. So there's 1, L1, L2, L3, L4. Top of the iliac crests, right? L4's got to be there. L5 is transitional segment. So maybe a wedge here at 4. Not a big smoking gun though. This is what I'm after. So we got a pedicle here without a mate. So that's a hemivertebra, full failure of formation. And is it segmented or partially segmented? Is it fully segmented or partially segmented? There's a beautiful disc space. Don't see one here. It's completely fused, so it's partially segmented. Supernumerary hemivertebrae. Yep, everything I just said. What's going on here? Oh, this is another geek alert, I think. So at least we get a CT cut here. So here, even with this 3D reconstruction, there's all sorts of stuff going on. There's a spina bifida, looks like here. But you can definitely see, let's see. We got an extra rib here. See where the normal ribs are. So here's 2. Let's see. There's 2. That's normal. So yeah, this is just, we better look over here in the CT because it looks like there's an extra rib. So here it's kind of hard to see. I mean, is that a bone bar there? It looks like a bony bar, right? It's kind of hard to tell on this one. But I mean, on this, there's no question. We'd have to look at a cut through this. I think there's a bone bar right here. Yep, these are all unilateral bar, I think. Although we have in that bar, what looks like a bar, we have this for sure. There's no question what that is. So that's a complete failure of formation, aka hemivertebra. And is it segmented or non-segmented? There's no segmentation. It's basically fused, so it's non-segmented hemivertebra. That's a tough one. Non-segmented hemivertebra. Yep, rudimentary ribs in there. Okay. Complete failure of segmentation anteriorly. Yeah, so what's a complete failure of segmentation? That's a block, so author's calling those blocked. Yeah, I guess I would agree with that. Yeah, that's better than a bone bar. I was looking here, but really the disc it does look like a block now. So, okay, I'll buy that. You can see some of these things are pretty tricky. Don't worry on the test. I'll try to keep it simple. Maybe extra credit one or something. Let's do another one. Now this is what I could put on the test. You guys can handle that. Just a simple block here. Run-of-the-mill block vertebra. But then you got to know what that means, because I might not say block vertebra. I may say a complete failure of segmentation. Another one. Whew, all sorts of stuff going. Look at this one. This would be a tough one. I'm not going to spend too much time here with it, but we got an absent pedicle here. So I don't know what's going on here. Sclerotic pedicle here, probably stress lines running through that. We got 2 pedicles. We got a huge wedge vertebra. So that's partial failure of formation here. Maybe a little wedge on top of that. I see 2 pedicles. Now this is pretty easy to pick out. So there's a hemivertebra right there. See, there's the big giant pedicle, and there's just a little wedge here, nothing else. There's no mate to it. 2 pedicles here for the bone affected, which would be That's the last rib. This is L1. So it's a supernumerary, and it looks like there's a disc space here, but not really much of one here. So it's a supernumerary hemivertebra between T12 and L1, which is partially segmented. This is a very busy one, isn't it? Here's another one. Look at this one. Actually it's like it stole the rib from T12. T12 doesn't have one, but it's up here. It's definitely a fully segmented. Look at there's disc spaces here and here. Fully segmented hemivertebra right here. AK for hemivertebra, complete failure of formation. You're starting to get it. I can feel you starting to get it. Okay, wonderful. We don't even need that. We don't even need that lateral, really. Check the kyphosis. Little, maybe hyperkyphotic. There's the answers. How about this one? Oh, this is kind of neat. So, complete failure of formations at, here's 5, 4, 3, and 2. Complete failure of formation posteriorly. So that's still that's a block vertebra. There's another one anteriorly. See why it's not good to say a bony bar? Although this would look like a bony bar from a P to A view or from a coronal CT. This one wouldn't, because it's fused here. That was an easy one. How about another hard one? That was so easy I didn't give you the answer. This one's tough, but at least it showed the scoliotic defect in the child. You can obviously see a fully segmented hemivertebra right here. There's another view of it. That's the CT. Oh, this is neat. There's an MRI, CT. And there's a child. There's the X-ray. See, the X-ray is just a mess. It's hard to tell. That's why MRI and CT, especially MRI, no radiation to a child. It's always better to get an MRI. Co-morbidities, approximately. I'm going to go on my rant. I'll probably cut it short and let you read it, though. 1/3. That's a huge number. 1/3 of all patients with congenital scoliosis have intraspinal abnormalities. Not good. One recent study, these abnormalities were categorized as the following. 30% of these kids had this, I like this when I do this even for myself in this word, diastematomyelia. Which we won't talk about now, but they can have almost as much have a tethered cord, syringomyelia, other stuff. So why not get an X-ray, right? Or why not get an MRI just to make sure? Why would you do a grade 5 adjustment on someone when you're not 100% sure if they have a tethered cord or a syrinx down there? Syrinx can occur, diastematomyelia. So do an MRI on these people. Management of scoliosis. Okay, here's where I already said this. I got into it with them, and I just don't agree that it's safe to adjust someone unless you find out just because of this. And I'm just trying to drive my point home. Shen, 2013, up to 43% of patients with congenital scoliosis have intraspinal abnormalities, diastematomyelia, syringomyelia, tethered cord. So for my class, for my test, an MRI needs to be performed before using grade 5 manipulation. So that's just my rule based on, I'm a very medical literature type guy, and so I'm not going to ignore that. You should also, even further, if the patient's under 21 and this is news to them, you probably should get an echocardiogram, or at least send them to a cardiologist and an internist to check for problems with the kidneys and heart as well, right? You're a primary healthcare provider. You're responsible for acting like a primary healthcare provider. Here's some more. 91 Bradford study. I go on and on. Quote, routine MRI screening in congenital scoliosis patients was suggested. I completely agree. I mean, here's Rothman-Signone. They say it seems reasonable to order an MRI systematically in a congenital scoliosis patient because of the high prevalence of these interspinal abnormalities. There's another one, Sue, or I don't know how you pronounce that. I think it's just Sue. Published another one. I mean, you get the point here. So that it said, considering the incidence of interspinal abnormalities of 31% in this study as clinical manifestations may not be detected, so you can't detect this on examination. They recommended, MRI is recommended in patients with congenital spinal deformity as part of the initial evaluation, even in the absence of clinical findings. So there's a couple studies I presented that supports my position. And I'm sorry, I do disagree with Palmer radiology on that one. Thank you very much, and we will see you. We have one more lecture next week. Will be week 10. And did I tell you when this is? This is fall 2016. Good luck on that test.